Hello and welcome. Today I am going to introduce to you a modeling tool that is used to inform workforce planning. It's called PACE-HRH. It's the Population-Aware Capacity Estimator for Human Resources for Health. This tool was developed by the Institute for Disease Modeling, which is a research team within the Bill and Melinda Gates Foundation. It's available for public download and for contribution at the GitHub link shown here. My name is Brittany Hagedorn. I am a senior research scientist with IDM, and I'm going to walk you through a little bit of an introduction to the tool. At the end, we'll come back and summarize some of the key aspects that differentiate this tool from others that you might be familiar with. Before we start, I just want to highlight that the method is pretty flexible, and it can be used across a range of scenarios. For example, to look across community health worker programs, or within different cadres within a country. The analysis can also be used at whatever geographical granularity is appropriate for your use case. So it can be used in aggregate at a country level, or all the way down to a much more sophisticated regional or even tailored to a local context, such as a health district. So this method is one approach to workforce planning, and we typically call this bottom-up time accounting. And the goal is to support program design. The intent is for this approach to be used to rationalize staffing ratios, think about distribution of the workforce, ensure the feasibility of proposed changes to a program, and ultimately generally to generate evidence as a planning and as an advocacy tool. For example, you might be familiar with the WHO's minimum target of 22 healthcare workers per 10,000 people, which is drawn from empirical evidence. The approach we propose here can be used to validate these types of ratios for staffing from a delivery system perspective and really tailor them to the local context. We want to consider things specific to the geography being modeled. For example, high local HIV burden or extended travel times needed to reach high-risk populations. This method is not intended to be a replacement, but is a complement to existing analyses that you might otherwise see, such as cost effectiveness, because it considers the logistical constraints in a way that is not typically captured. In addition, it generates a more dynamic view of how a healthcare system's functioning may change over time due to evolving populations and their health needs. The value add of this model then is to layer in data that speaks more to feasibility and a subnational context, and also to the population-specific needs. So this approach uses Monte Carlo simulation on a monthly time step to project forward populations, disease incidence, and seasonality. Monte Carlo is a standard approach to simulation and modeling, often used in financial services and operational research. The model generates stochastic values for annual fertility and mortality, broken out by age group, initial incidence rates and their annual rate of change, and the seasonal distribution of burden in a given year. We then translate this burden into capacity requirements by applying a number of contacts and a stochastic time per visit to each task. I'll emphasize here there are many sources of uncertainty in the parameters, and so in addition to an expected value analysis, sensitivity analysis should also be performed on key inputs, such as fertility rates. So the core of the model is the task list, and all of the tasks have these input parameters for them, and so you need to specify all of these before you run the model. You start with the name of the task, the relevant population, and the incidence rate. The population and the incidence rate will be used to calculate how many people in a given year receive the service. So for example, with measles vaccination, that should apply to all children under age 1 year, and then 100% of those we would target for vaccination. If you have coverage rates, you can use that instead here. But in this case, we're assuming that we want all children to be vaccinated, and we're estimating an ideal workload. And so we would use 100% for that task. Now, once you've calculated the number of people who are eligible for the service, we also want to know how much time it actually takes to do this. So those number of people are multiplied by the number of contacts within the health system. So for example, with measles, we would expect children to have 2 doses. So there's 2 contacts. a time per contact, for example, 5 minutes, and then those values are all multiplied together to estimate the total workload in a given year. Now, for measles, we would expect that vaccination ideally should remain at 100%, and so there might not be any change. Our annual change rate in incidence could be 1 in that case. But if we have something like malaria, which we would hope is decreasing over time, we would put an annual change rate in, and that value would be below 1 to reflect that the rate is decreasing year on year. We then also assign this task to a specific cadre. So this is flexible. You can name these anything you'd like, but that helps you then total at the end how much workload is going to go to each staff member who's included in the model. Now, there's also other tasks that aren't specific to a population ratio. These would be things like trainings, community engagement, travel, overhead. All of those things you can also put into the model, but they're done on an hours per week per staff member basis. So you can add those, but you put them in a little bit differently. Note that there's no limit to the number of tasks that can be specified in either of these. So I'm not going to go through all of the input sheets today, but I do also want to highlight the fertility and mortality rates because this is also critical for the model's functioning. It basically drives the demographics forward in time. You see both fertility and mortality specified here in the type column. The sex that applies to, the age band, these are flexible. This is an example, this is a screenshot of how we have it set up in the base model, but you could change these to be as broad or as narrow as you would like, depending on the specificity and the data you have available to you. And then you have that initial value. So what is the fertility and mortality rate for this age band in year 1 of your model? And then that change rate functions just like we just talked about. It is applied year on year to generally to decrease both fertility and mortality. Those rates tend to be falling in most countries. And so these would generally be values below 1. So as you may have guessed from this previous screenshots, the interface for the model is built into Excel. So all of the data management and the assumptions that you want to put in, that all happens there. However, the simulation model itself is written in R and it's installed as a package. This allows us to run a lot of simulations very quickly and get a much more robust result by using R as our base package. The modeling technique is Monte Carlo simulation. And what that is, if you aren't familiar with it, what it does is it samples repeatedly from a distribution that we specify and then generates a randomized outcome that captures uncertainty. So this is important because much of our data are assumptions that go into the model, for example, incidence or mortality rates. There's some uncertainty around where those are starting today. And so we sample from a range of values that might be true within some reasonable assumptions to capture the uncertainty in what we know about those parameters. We also then are generating, using that stochasticity and applying that forward, and we continue to sample into the future. So it's not just where are we starting today that is uncertain, but it's also how the future will unfold. We may have, for example, fertility projections, but we don't know for sure how choices are going to change, how culture is going to change, how access to care or political values are going to shift. And so we capture some of that uncertainty by continuing to use this Monte Carlo sampling technique and capturing that uncertainty into the future. In this model, we sample both the initial value and those year-on-year rate of change. So those annual rates of change we were just looking at, those are also sampled. This is applied to all of the parameters that you see listed here. The good news is you don't actually need to have much, if any, coding experience in R in order to run the model. The setup is quite straightforward, and you just need to be able to click a few buttons once you have your Excel interface all populated with the input data. So now we are on to the fun part. These are some examples of the result summaries that are possible to generate using the outputs of the model. So once the model runs, it has all of this detailed data and it spits out a number of summaries for you to work from. all of the raw data is still available if you need it, but generally I find that the summaries are adequate for the work that I need to do and are used to generate plots like these. On the left, you see an example of the mix of services. So the box size here is the amount of time spent on a given service. And you can then start to get a sense of relative priorities. This is important for the modeling results themselves to understand how a health worker's time is being spent, but it's also really important for validation and understanding where you might need to hone in on your assumptions. So in this case, for example, I want to be really careful about getting my pregnancy and my nutrition assumptions right. I can worry a little bit less about uncertainty in, say, malaria or NTDs because they aren't a huge component of the results. And so it's a little bit more important for me to focus in my energy in getting those assumptions for the larger components closer to perfect. In the middle there, we see time requirements. This is shown by category, so there's different kinds of clinical services. We've grouped them here, and you can see that change over time. You can also generate these plots, for example, by cadre of worker. And then on the right, we see changes to care volumes over time. So it's not just enough to understand on the far left how much time this is showing for 2021, how much time would be spent on certain clinical services, but we want to understand how that would shift into the future. So here you would see things like, generally we would find in populations, NCDs, things like diabetes, hypertension. These are growing in many of our populations as they age. And things like tuberculosis, malaria are declining because we are putting in better control methods, right, and doing a better job of treatment. So we can see how those dynamics will shift over time. We can also look at seasonal fluctuations. So not every month is average. Some months have more work than others due to malaria seasonality, birth seasonality, things of that sort. We can look at these shifts over time. And we can subset these by cadre of workers or by types of services to get into more specificity. So scenario analysis is the last thing I want to talk about. And this is really important because to have an easy interface for scenario analysis, because I may want to run quite a few different permutations of the model. For example, if I want to run a whole suite of regions that have the same services but have different demographics. Or if I want to compare different sets of service packages. I don't want to have to change Excel sheets and do a bunch of manual work to manage that. And we've set it up so that you don't have to. There's a fairly straightforward scenario manager that allows you to make some of those changes as you'd like. It's also important for sensitivity analysis to be able to manage these scenarios easily, because you may want to test, for example, what is the contribution to the change over time of fertility, right? Let's turn this on and off. Let's manage some of those variables and see what is the contribution of different assumptions that we've made. And so we're able to use this scenario manager to do this type of sensitivity analysis. There's a number of variables that we would expect that I know I personally have wanted to use, and you may also want to use for testing. And so we've included those in the default package. So just to wrap up then, PACE-HRH is a model that's available freely to use by anyone who wants to explore capacity planning for the health workforce. The easy-to-use Excel interface is great for new users, but also it's supported and powered by a robust package that's built in R. The pre-built scenario manager and the sensitivity analysis options make this really nice to use for a researcher or for a policymaker who wants to explore a range of scenarios without spending a ton of time to manage all of those details. Additionally, optionally, there is an analysis pipeline which is written in R and generates plots such as those that you saw earlier. And this makes for a really nice results presentation that are easily modifiable. Additionally, if you want to, you can do this in Excel if that's your preferred mode of working. From a technical perspective, Monte Carlo simulation really steps up the complexity and the management of the uncertainty of the future. There's a lot of uncertainty in our variables in public health and in planning, and so this enables us to capture that in a robust way. It also allows us to look at seasonality and how that affects service demand and ultimately workload. And then last, optionally, you can think about allocating that workload by cadre. So if you're thinking about a team, if you're looking at a district, something a little bit larger, you can think not only about total load, but about who's responsible for doing what and whether or not that is balanced. This is especially helpful if you're thinking about bringing in new cadres of workers or expanding your workforce. That timing, the balance between different sets of workers is important to consider, and this enables you to do so.